Good morning, everyone. Today we'll be looking at one of the most clinically important topics in pharmacology, cardiovascular drugs, specifically antihypertensives and diuretics. As future doctors and pharmacists, you'll see these medications prescribed daily, sometimes for life. So understanding not just the names, but also the mechanisms, clinical uses, and potential pitfalls is crucial. Our learning objectives today are fourfold. First, we'll classify the major antihypertensive drugs, because classification gives you a mental map for remembering the details. Second, we'll explore the mechanisms of action. Knowing why a drug works helps you predict its effects, even for drugs you've never seen before. Third, we'll cover diuretic classes and their uses, as these overlap with hypertension treatment but also have unique indications. Finally, we'll discuss adverse effects and contraindications, the don't miss part, because real-world prescribing is as much about avoiding harm as producing benefit. This will be a mix of pathophysiology, pharmacology, and practical clinical pearls. Let's start with the big picture: hypertension. Clinically, we define it as a persistent office blood pressure of 140/90 millimeters of mercury or higher. But it's more than just a number. The pathophysiology involves three main levers: peripheral resistance, cardiac output, and blood volume. Imagine the vascular system like a network of pipes. You can raise pressure by tightening the pipes. That's increased peripheral resistance. By pushing more fluid through them faster, that is increased cardiac output, or by simply having more fluid in the system or increased blood volume. These mechanisms explain why so many different classes of drugs can lower blood pressure. They each target different levers. The consequences of uncontrolled hypertension are severe: stroke, myocardial infarction, congestive heart failure, and chronic kidney disease. It's called the silent killer because patients often feel fine until organ damage is advanced. So, our therapeutic goal is to bring blood pressure down in a way that prevents these complications without introducing new problems from the drugs themselves. Now, classification. Think of this as your mental filing cabinet. First, diuretics, thiazides, loop diuretics, and potassium-sparing agents. Then sympatholytics, which blunt the effects of the sympathetic nervous system, beta blockers, alpha-1 blockers, and centrally acting agents. We also have vasodilators, which act directly on vascular smooth muscle, and calcium channel blockers, which limit calcium entry into muscle cells to reduce contraction. Finally, the RAS inhibitors, ACE inhibitors, angiotensin receptor blockers, and renin inhibitors, which target hormonal regulation of blood pressure. A useful mental model: diuretics reduce volume, vasodilators reduce resistance, beta blockers reduce both rate and force of the heart's pump, and RAS inhibitors modulate hormonal vasoconstriction. You'll see that patient comorbidities like diabetes, heart failure, or asthma often steer the drug choice. Let's zoom in on diuretics as antihypertensives. The key principle here is that blood pressure depends on the amount of blood in the circulation, the blood volume. Diuretics work by prompting the kidneys to excrete more sodium and water, which reduces plasma volume. With less volume, the heart pumps against less load, and cardiac output decreases. Initially, that's the main effect. But interestingly, with chronic use, cardiac output tends to return to near normal, and the long-term blood pressure-lowering effect comes from a sustained decrease in peripheral vascular resistance. The body adapts in that way. Now, we classify diuretics into three main types relevant for hypertension: thiazides, loop diuretics, and potassium-sparing diuretics. Thiazides, such as hydrochlorothiazide, are our first-line choice for most patients with uncomplicated hypertension. Loop diuretics like furosemide are much more potent but are usually reserved for cases of resistant hypertension or for patients with significant fluid overload, such as in heart failure. Potassium-sparing diuretics like spironolactone or amiloride have relatively weak diuretic action but are important adjuncts, especially to prevent hypokalemia caused by other diuretics. Here's the clinical pearl: the choice of diuretic is not just about potency. It's about matching the drug to the patient's volume status, renal function, and comorbidities. A patient with mild hypertension and normal kidney function? Thiazide. A patient with swollen legs from CHF and high blood pressure? Loop diuretic. A patient who develops dangerously low potassium on a thiazide, add a potassium-sparing agent. Remember, overdiuresis can cause hypotension, electrolyte imbalances, and kidney injury, so monitor patients closely. Thiazides are the quiet workhorses of hypertension management. Hydrochlorothiazide and indapamide are classic examples. They act in the distal convoluted tubule of the nephron, where they inhibit the sodium chloride symporter, leading to increased excretion of sodium, chloride, and water. This results in a modest diuresis, not as dramatic as loop diuretics, but just enough to lower plasma volume and, over time, cause vasodilation. In practice, thiazides are highly effective in reducing systolic blood pressure, especially in older patients and in Black patients, who often respond less well to ACE inhibitors alone. They are inexpensive, orally active, and generally well tolerated, which is why they are first line in many guidelines. But, and there's always a but, in pharmacology, thiazides can cause metabolic side effects. Hypokalemia is the most common. They increase potassium loss in the urine. They also can cause hyperuricemia, which may precipitate gout, and they can mildly increase blood glucose and cholesterol. One way to remember the adverse effects: think hypo, hyper, hypokalemia, hyperuricemia, hyperglycemia, hyperlipidemia. Clinically, that means you check electrolytes after starting therapy and warn patients about possible gout flares. Finally, they lose efficacy when renal function is poor. If the glomerular filtration rate drops significantly, loop diuretics become more effective. Loop diuretics like furosemide and bumetanide are the sledgehammers of diuresis. They act in the thick ascending limb of the loop of Henle, inhibiting the sodium, potassium, 2-chloride transporter. This region normally reabsorbs about 25% of filtered sodium, so blocking it results in a huge loss of sodium, water, and, importantly, calcium and magnesium. Because they are so potent, loop diuretics are rarely used for routine hypertension. Instead, they are reserved for situations where rapid and profound fluid removal is necessary, for example, in acute pulmonary edema, advanced congestive heart failure, or severe edema from nephrotic syndrome or liver cirrhosis. In the context of hypertension, you might use them in patients with chronic kidney disease who do not respond well to thiazides, or in cases of resistant hypertension with volume overload. Adverse effects are similar to thiazides in terms of hypokalemia and metabolic alkalosis, but they have their own dangers. Ototoxicity, hearing loss, is a rare but serious complication, especially at high doses or in combination with other ototoxic drugs like aminoglycosides. They can also cause hypocalcemia, unlike thiazides, which tend to retain calcium. Clinically, loop diuretics are powerful tools, but they require careful dosing and monitoring. Overzealous use can cause dehydration, low blood pressure, and kidney injury. Potassium-sparing diuretics are a diverse group united by one feature: they help the body retain potassium while promoting sodium excretion. The two main subtypes are aldosterone antagonists, spironolactone and eplerenone, and epithelial sodium channel blockers, amiloride and triantarene. Aldosterone antagonists block the effects of aldosterone at the mineralocorticoid receptor in the collecting duct. This reduces sodium reabsorption and potassium excretion. They are particularly valuable in conditions with excess aldosterone, such as primary hyperaldosteronism, and in heart failure with reduced ejection fraction, where aldosterone contributes to cardiac remodeling. Epithelial sodium channel blockers like amiloride act directly on sodium channels in the collecting duct, reducing sodium reabsorption and potassium loss. They are weaker as diuretics, but are often used in combination with thiazides to counteract hypokalemia. Adverse effects include hyperkalemia, which can be life-threatening, especially in patients with renal impairment or those taking other potassium-retaining drugs like ACE inhibitors. Spironolactone can also cause gynecomastia and menstrual irregularities due to its anti-androgen effects. Eplerenone is more selective and has fewer endocrine side effects. In hypertension, potassium-sparing diuretics are rarely first-line but can be invaluable in specific scenarios, particularly when hypokalemia is a recurring problem. Beta blockers are one of the most widely recognized cardiovascular drug classes, and for good reason. They're versatile. The classic examples you'll encounter include atenolol and metoprolol, which are cardioselective. They primarily block beta-1 receptors in the heart, and propranolol, which is non-selective, that is, blocks both beta-1 and beta-2. The primary blood pressure-lowering effect of beta blockers comes from reducing cardiac output. They slow the heart rate, or negative chronotropy, and reduce contractility, or negative inotropy. But there's more. By blocking beta-1 receptors in the juxtaglomerular cells of the kidney, they reduce renin secretion, and this dampens the renin, angiotensin, aldosterone system, RAS, further reducing vascular tone and volume. Clinically, they are particularly valuable in patients who have hypertension alongside other conditions such as angina, prior myocardial infarction, arrhythmias, or heart failure. They improve survival after myocardial infarction and in certain types of heart failure. But, importantly, not all beta blockers are suitable for heart failure. Only those with proven benefit, like bisoprolol, carvedilol, and metoprolol succinate, are recommended. Adverse effects vary with selectivity. Non-selective beta blockers can precipitate bronchospasm by blocking beta-2 receptors in the bronchi, so they're generally avoided in asthma and COPD. They can also mask hypoglycemia symptoms in diabetics by blunting the adrenergic warning signs like tremor and palpitations. Common side effects include fatigue, cold extremities, and bradycardia. Calcium channel blockers are divided into two major groups: dihydropyridines like amlodipine, nifedipine, and non-dihydropyridines, verapamil, diltiazem. Dihydropyridines act mainly on vascular smooth muscle, causing vasodilation and reducing peripheral resistance, which is why they're effective in lowering blood pressure. Non-dihydropyridines act on both the heart and vessels, slowing conduction through the AV node, reducing heart rate, and mildly lowering contractility. In hypertension, amlodipine is a favorite. It's long-acting, well-tolerated, and safe in a wide range of patients, including those with asthma and diabetes. It's also particularly effective in elderly patients with isolated systolic hypertension, where arterial stiffness is a problem. Adverse effects depend on the type. Dihydropyridines often cause reflex tachycardia, especially short-acting ones like nifedipine, which is why long-acting preparations are preferred. Peripheral edema is common due to increased hydrostatic pressure in capillaries from preferential arteriolar dilation. Non-dihydropyridines can cause bradycardia, heart block, and worsen heart failure in susceptible patients due to their cardiac depressant effects. Clinically, think of dihydropyridines as vascular specialists and non-dihydropyridines as cardiac specialists. You wouldn't use verapamil in a patient with AV block, but you might in someone with hypertension and atrial fibrillation. Finally, a note on drug interactions. Verapamil and diltiazem inhibit CYP3A4 and can raise levels of drugs like statins, so dose adjustments may be necessary. ACE inhibitors, enalapril, lisinopril, ramipril, target the RAS pathway by blocking the enzyme that converts angiotensin I to angiotensin II, a potent vasoconstrictor. The result is vasodilation, reduced aldosterone secretion, and, over time, reduced sodium and water retention. They're especially beneficial in patients with diabetes. They protect the kidneys by reducing intraglomerular pressure, in heart failure and post-MI. In fact, for a hypertensive diabetic, an ACE inhibitor or an ARB is often the first choice. Adverse effects are important to remember. The most common is a persistent dry cough, caused by increased bradykinin levels. This same bradykinin effect can cause angioedema, rare but potentially life-threatening swelling of the face and airway. Hyperkalemia can occur because aldosterone secretion is reduced, leading to less potassium excretion. They're contraindicated in pregnancy due to risk of fetal renal damage and in patients with bilateral renal artery stenosis, where they can precipitate acute kidney injury. A useful prescribing pearl: start with a low dose, check renal function and potassium within 1 to 2 weeks, and educate the patient about reporting swelling or breathing difficulty immediately. Angiotensin receptor blockers, losartan, valsartan, candesartan, target the same pathway as ACE inhibitors, but at a different point. They block the AT receptor, preventing angiotensin II from exerting its vasoconstrictive and aldosterone-stimulating effects. They have similar benefits to ACE inhibitors in hypertension, heart failure, and diabetic nephropathy, but importantly, they do not increase bradykinin levels. This means they rarely cause cough or angioedema, making them excellent alternatives for patients who can't tolerate ACE inhibitors. Adverse effects include hyperkalemia and hypotension, especially when combined with other antihypertensives or potassium-retaining drugs. They share the same pregnancy contraindication as ACE inhibitors. In clinical practice, if a patient develops cough on ramipril, switching to losartan is a common next step. Centrally acting drugs like clonidine and methyldopa work at the level of the brainstem. They stimulate alpha-2 adrenergic receptors in the medulla, reducing sympathetic outflow to the heart and blood vessels. The result is reduced heart rate, cardiac output, and peripheral resistance. Methyldopa is particularly famous for being safe in pregnancy. It has decades of use for gestational hypertension. Clonidine, meanwhile, is useful in resistant hypertension but is often limited by side effects such as sedation, dry mouth, and constipation. A key caution: abrupt withdrawal of clonidine can cause rebound hypertension due to a sudden surge of sympathetic activity. Always taper gradually. Because these drugs act centrally, they can cause drowsiness and are generally not first-line outside of pregnancy or specific refractory cases. Hydralazine and minoxidil are direct vasodilators. They act on arteriolar smooth muscle to relax it, lowering peripheral resistance. Hydralazine is sometimes used in severe hypertension, hypertensive emergencies in pregnancy, or in combination therapy for heart failure in certain populations. Minoxidil is extremely potent and is reserved for severe, refractory hypertension, and yes, it's also used topically for hair growth. The downside of potent vasodilation is reflex sympathetic activation, increased heart rate, increased renin release, and fluid retention. This is why vasodilators are often combined with a beta blocker and a diuretic. Hydralazine can cause a lupus-like syndrome, especially in slow acetylators, and minoxidil can cause hypertrichosis, excessive hair growth. Guidelines recommend starting with lifestyle changes, salt restriction, weight loss, physical activity, then moving to drug therapy. Thiazides, ACE inhibitors/ARBs, or calcium channel blockers are first line for most. Combination therapy is often needed as hypertension progresses. Resistant hypertension may require adding a loop diuretic, vasodilator, or centrally acting agent. This table condenses mechanisms, examples, and adverse effects. This table is more than an exam tool, it's a clinical quick reference. When faced with a hypertensive patient, mentally run through this list. Which mechanism do I need? Which adverse effects are unacceptable for this patient? Which comorbidities might shift my choice? This is the beginning of clinical reasoning in pharmacology. So, what do I really want you to walk away with today? First, there's no single best antihypertensive for everyone. The best drug is the one that matches the patient's physiology, comorbidities, and lifestyle, while being safe and affordable. For example, in a young patient with hypertension and migraines, a beta blocker might address both problems. In an elderly patient with isolated systolic hypertension, a calcium channel blocker may be superior. Second, hypertension management is dynamic. Patients' conditions change. Renal function may decline, side effects may appear, new diseases may emerge, and therapy should adapt. A patient who tolerates hydrochlorothiazide well for years might suddenly develop gout. Now you reassess. Third, monitoring is not optional. Every antihypertensive drug has potential adverse effects that may not be obvious to the patient until damage is done. Checking electrolytes with diuretics, renal function with ACE inhibitors and ARBs, heart rate with beta blockers, and watching for edema with calcium channel blockers is standard practice. Fourth, combination therapy is the norm. Most patients will require 2 or more drugs from different classes to reach target blood pressures, especially if they have comorbidities or more advanced disease. Drugs with complementary mechanisms not only improve control, but often minimize side effects by allowing lower doses. Fifth, lifestyle modification is the cornerstone. You cannot outprescribe a diet heavy in salt, a sedentary lifestyle, and uncontrolled stress. Even the most potent drugs will fail if the underlying causes aren't addressed. Finally, patient education and adherence are as critical as pharmacology. Patients need to understand why they're taking these medications, what to expect, and when to seek help. The best treatment plan is worthless if the patient doesn't follow it. Think of these points as the spine of your practice: mechanism, patient match, monitoring, combination use, lifestyle, and adherence. Everything else is detail layered on top. Thank you for watching. I will see you in the next lecture. Also, like, share, and subscribe.